Hi, everyone. Welcome. Good evening. Thanks so much for joining us. While everyone is signing in, I hope everyone finds a comfortable place to enjoy tonight's webinar. Maybe you can tell us, say hi in the chat and tell us where you are joining us from. Columbus, Ohio. I love it. Phoenix, Arizona. Okay, now they're coming in. I love it. Okay, let's see if I can keep up. Oh my goodness, all over. I see LA, Texas, Lambertville, New Jersey, Washington State. Hello from Germantown, Maryland, Texas again, Toronto, Georgia, Florida, more Toronto, West Coast, Connecticut. We're so happy to have everyone join us this evening. Thank you. Daytona Beach, Florida. Amazing. Nashville, Minnesota, NorCal. Ooh, I'm NorCal. Amazing, everyone. Thank you again. Wonderful. Well, thanks so much for joining us. My name is Madison Alig. I am the VP of Growth and Clinical Relations at Radimal, and I am so happy to have you join us for our next race-approved Radimal case rounds. If this is your first time joining us or hearing about Radimal, Radimal is a leader in veterinary diagnostics. We combined web-based PACS with AI to power initial assessments and board-certified specialist consultations to help deliver veterinary teams fast and reliable imaging results 24 hours a day, 7 days a week. And today's session is going to be all about small animal pulmonary radiographs. So how do we confidently interpret thoracic radiographs, obtain diagnostic quality images, and avoid any common pitfalls? And I'm excited to introduce you to tonight's speaker, Dr. Embriano. Before I pass everything over to Dr. Embriano, just a few general info for tonight's session. As I mentioned, tonight is a race-approved session, and you will all receive your CE certificates via email in the next few days with the email address that you use to register for tonight's session. And with that, I will turn it over to Dr. Embriano. And lastly, we're going to answer all of your questions at the end. So as they're coming up, just put them in the chat, and then we will come to answer all of them at the end. Thanks again, everyone.
All right. Thank you very much, Madison. I appreciate that. Hello and welcome. This CE event, hosted by Radimal, is going to discuss small animal pulmonary radiography. Um, and so we're just going to jump right into it. Just a little bit about me and my pedigree. Recently, I started at Cornell University and Stanford, their satellite hospital. I did my residency at Auburn and done a few externships and internships here and there, some small animal clinical radio emergency, and my education at Penn and UConn. And I started with Radimal as soon as I finished my residency. One of the first places I worked as a radiologist and continue to work. And man, things have changed a lot and all for the better. It's been a really positive experience overall. So I'm excited you guys are here to help us out and everyone learn a little bit more. If you guys learn just one or two things, I think that's going to be a huge win. Don't get overwhelmed. Just try to pick out a few pieces that you think will move you in the right direction. That's all I look for in a CE event for myself personally. So just looking at the roadmap here, what we're going to discuss, we're going to talk about some basics of, what are radiographs, how do they work? We're going to go over normal pulmonary anatomy. We're going to talk about how to obtain really good quality, greatest of all time, GOAT images. That input of good quality images is going to severely affect the output of, how we interpret them and how we, make decisions for our patients. And we're going to review pulmonary patterns, what's normal, what's abnormal, and we're going to supplement that with some case examples. So going back to radiographic basics, radiographs are projection images. They're shadows, basically. And I really like this picture of the octopus because I think it highlights how it can be pretty deceiving at times. We're compressing, a 3D animal into 2D, and with that, you're going to make some sacrifices and change some things in how they look. We have the five major opacities. If you don't remember, it's gas, fat, soft tissue, mineral or bone, and then metal. But there's shades of gray in between. So those are the five basic opacities. But if you have, say, a centimeter of fat and a centimeter of soft tissue, the same volume, they're going to look very different in terms of their radiographic appearance, in terms of which one's more attenuating of the X-ray beam, which one's more white. But if you have, say, 7 centimeters of fat and 1 centimeter of soft tissue, then they're going to be closer together in similarity in terms of their overall opacity. So, the tissue volume makes a big difference too. There are two, nomenclature terms that I think are important to keep in mind. One is border effacement. That's essentially when you have two structures that are the same opacity, so soft tissue and soft tissue, or fat and fat, touching one another. And when they're in contact, you can no longer discern the borders of those two structures. You can no longer tell which is which, and that becomes important in disease. And the other important terminology is superimposition, and that is an additive attenuation or increased opacification or whiteness as you add more anatomy through the X-ray beam. So they don't have to be touching, but if you have, one kidney and the other kidney partially superimposed with one another on a lateral view, those two poles where they're superimposed are going to be more white than, say, the poles on either side that aren't superimposed. And so that's the additive attenuation or the superimposition. Moving on to normal anatomy, it's important to think about what regions of the lungs, or what parts of the lungs there are, just a general idea of where each lobe is. So we have the cranial lung field, which includes the right and left cranial lung lobe. In the right middle lung lobe is a little bit more ventrally seated. It doesn't have much of a dorsal portion. And the analogous portion of the right middle is the caudal segment of the left cranial on the other side, which shares a bronchus with the cranial segment. So it's technically one lobe on the left side, but they just have a bifurcation pretty early on. And then the large area of triangle in the caudodorsal lung field is your right and left caudal lung lobes, and they're on either side. And in between those, and ventral to that caudal vena cava, is going to be your right accessory lung lobe in the middle. For the VD projection, just kind of highlighting those lobes again. Again, we have the caudal lung field has the two large caudal lung lobes with the accessory lung lobe in the middle. The cranial lung lobes, in which the left cranial is segmented into two portions, the cranial segment and the caudal segment, by this fissure. One thing I do want to highlight is that this right middle lung lobe, it's situated here in this image or in this diagram. Sometimes it will kind of position itself more medially and caudally over here, almost superimposed with that right ventricle. So just be aware that sometimes a right alveolar infiltrate or a right mass in the middle lung lobe will actually show up down here more on the VD view. Another thing I want to highlight too is that notice how this right cranial lung lobe kind of encroaches onto the left side. It kind of herniates through the diaphragm a little bit, or sorry, the mediastinum a little bit. And so that's what creates that craniomediastinal reflection, that herniation, and kind of protrusion, kind of taking up some of that left craniomedial chest. And that is important because it is a topic where I get a lot of comments about whether or not this is pathologic or not. And this is that lung herniation right there. And because it's extending through that mediastinal reflection, it creates a little bit of a soft tissue band around it, which gives it the artifact. It gives it the impression that it's like a bulla or some kind of pathologic process. But that's actually normal to see on the lateral views to some extent. This one's a bit more pronounced compared to some other ones, and it's more of a dog thing than a cat thing. But I just want to make that aware because I do get that question a lot. In terms of normal anatomy and what to consider normal, what not to get overexcited about, I think it's important that we discuss how the lungs are going to look a little busy. The lungs are not just gas, they're not just alveoli and bronchi. There's vasculature, there's lymphatics, There's the interstitial tissues, the connective tissue, the elastin. That's all soft tissue opaque. It's the alveoli and the bronchioles that contain the gas and are, then portion of the lung, which is why it's fairly radiolucent. But there is soft tissues there, and so there is going to be some heterogeneity and some bronchial markings, and a little bit of busyness. So I just want that to be kind of in the back of your mind at all times. Um, you can normally see bronchial markings, and there is a trend with middle-aged and older dogs, especially, and dogs with endocrine disorders, where they will develop bronchial wall mineralization. And that is not necessarily associated with pathology or bronchitis. And so that's a frequent issue that comes up a lot as well when I'm discussing cases, is differentiating the bronchial wall mineralization from bronchial disease. Bronchial wall mineralization is going to be, well-defined, conspicuous bronchial markings with a very thin wall. And if it's very thin and very conspicuous to your eye, it can't be soft tissue opaque. It has to be mineral at that point. So that can kind of help you differentiate pathology versus incidental changes. Another highlight to note is, like, looking at all this stuff, busyness is going to depend somewhat on the degree of inspiration. And so what we're trying to do is get peak inspiration. Now, I'm not just saying that, from my ivory tower saying, get peak inspiration. I understand that dogs and cats are not always cooperative, and I understand they can be painful or anxious or panting from discomfort. So, I just want to let you know that I'm aware that it's not always possible, but I'm just letting you know that it's the goal. But it can be difficult. But it is really the goal that we need to strive towards. Another highlight with busyness is that lateral radiographs will look a little bit more busy than VD and DV views. And that's because you don't have two pairs of lungs superimposed with one another. You just have one. You don't have a mediastinum superimposed with both lung fields. You just have the body wall. So it's pretty typical to see that busyness on the lateral views. So if you see something suspicious on those views, I would encourage you to look at the VD and the DV view to confirm if you see that there as well. If you don't, then you should make it more speculative and be more wary about calling it as definitively a problem. The right caudal lung lobe has more pulmonary vessels over in this medial aspect, and also the caudal vena cava superimposed. So that can look a little more busy as well in that region on the VD and DV views. So there's another thing to be aware of. And then for expiratory patterns, the timing could be off. They could be sedated or anesthetized. They could be panting. They could have, a big abdominal mass that prevents them from inflating their lungs. So there's other reasons too, but those are the most common. Is the timing is off and sedation. This is just a blow up of those same images, where you can just kind of appreciate how there's just a generalized busyness that's a little bit more pronounced than, say, in the lungs on the VD view, and this area here just being more busy because of the number of vessels and the caudal vena cava. Another really, really important concept that I want to highlight is nodule fakeouts. One of the most common reasons we take thoracic images is to, look for evidence of metastatic neoplasia. And it's difficult if you're unfamiliar with, how subtle a pulmonary nodule can be at its smallest size. So I just want to highlight that nodule fakeouts are areas that we want to become a little bit more familiar with. And those are going to be your end-on pulmonary vessels and pulmonary osteomas, or benign pulmonary osseous metaplasia you'll see sometimes. So the highlight of these is that they're very, very small, and they're very, very well defined. They have very sharp, well-defined margins, and they're almost mineral opaque. Now, the smallest pulmonary nodule of metastatic concern is going to be soft tissue opaque in 99% plus of cases. Very rarely do you have mineralized pulmonary nodules of metastasis. So at that size, the largest nodule you can really see is about 4 to 5 millimeters, getting closer to 3 millimeters with the very high-end, expensive machines. But for most machines, we're talking about 4 to 5 millimeters in diameter. So these end-on vessels and these osteomas are often much smaller. Sometimes the osteomas can be a little on the bigger side, but generally they're pretty small. And so just keep that in mind. If you're seeing these really small 3 millimeter, 2 millimeter well-defined nodule fake outs, keep in mind that these are probably end-on vessels or osteomas. And just to further highlight that, these are metastatic pulmonary nodules in a very blown up image of a dog's chest. And you can just see how subtle those lesions are. Their conspicuity is much less detailed. You can't make out their margins nearly as well. They're not nearly as opaque. They kind of blend in with the interstitium. So that's what you're looking for with very small nodules. And that's why we need to get really, really good images to make sure we're not missing stuff. For radiographic standards, we want to make sure we're taking three views in pretty much every instance, with exception of like two placement images. The reason being is we're only really evaluating the non-dependent lung. So the image on the left here is a CT scan of a dog in lateral recumbency and a radiograph in lateral recumbency. And just look how much atelectasis is on the dependent side, and you have much more increased attenuation of that lung compared to the non-dependent one. So when you're taking a radiograph, you're mainly looking at this lung, the non-dependent lung. So you're not doing a full pulmonary exam if you're just taking two views at this point, if that makes sense. Another thing with standards, want to make sure if the patient's really rotated, that can really affect, that we're seeing all the lung, what anatomy is superimposed with that lung. And also, there's a ton of other structures that we evaluate unrelated to the lungs that are affected and become unfamiliar to our eyes or look different or odd when they're rotated. And so we just want to make sure we retake those images and train our staff what to look out for to prevent doing that. Another, probably a pretty obvious one is making sure that the thoracic limbs are pulled cranially. We want to make sure we can see the cranial lung field, the mediastinum, not have like a mediastinal mass fake out, that sort of thing. And the same on the VD view. You can't really assess the cranial mediastinum if they're really rotated. Um, Whole body radiographs are problematic for a number of reasons. One of them has to do with algorithms. Another one is, like I said, those pulmonary nodules being very, very subtle. You're not going to see that on whole body images just because the spatial resolution is lower. You have more scatter radiation that makes the contrast resolution lower. You're just making so many, the lungs take up so many fewer pixels. So, so for metastatic screening, whole body radiographs are not the standard of care and are not indicated and are not sensitive enough, really. With the algorithms, it's a problem in that when you choose a whole body preset, when you're picking the images for the patient on the X-ray computer, um, those presets they do certain things when they're digitizing that image and all the coding that goes into developing that image and how it looks. And so when you're taking an image with an abdominal algorithm or preset or a whole body algorithm or preset, you're actually doing things that make it so that you're not able to look at the lungs as well as you should be. Um, so we'll get into that a little bit more details, but that's just something to keep in mind. We've already talked about expiratory radiographs. For quality control, I think a workflow is really important. When I was in small animal ER, what I would try to do is order the images and be around or nearby radiology when they're taking them so that I can look at the images right when they've been done and the animal's still in the X-ray suite. And that way you can say, okay, these look great. Bring the animal back to the cage or back to the owner or wherever, or nope, we need to retake those. There's a problem with this one, and that way, they're not already back with the client. You have to take the dog back or another day maybe have to do it and retake them. So that's something you should try to work into your workflow at the clinic. And it's a little more difficult, easier said than done, but I found it extremely helpful. And just make sure when you're looking at your images to have a systemic approach. It doesn't have to be a certain way, but just like you do your physical exam the same way every time, you're going to look at the images the same time. Kind of already talked a little bit about how peak inspiration is the goal. Expiratory images can be really problematic, and they can be inconclusive at best or misleading at worst. And so, we want to do right by the patient and we want to try to get it right the first time. And so, really getting the best images we can with peak inspiration being the goal, because most disease is going to increase the opacity of the lungs, not decrease them. There are some things like bulla and emphysematous diseases that will increase the lucency of the lungs, but most diseases that we're looking at and concerned with increase the opacity. So if we have nicely aerated lungs to contrast with that soft tissue disease, that's going to give us the best chance of seeing it. Just another example of expiratory versus inspiratory. This is an anesthetized patient getting a dental, and the dog was not oxygenating well at some point through the procedure, so they took radiographs. You can see the dog's intubated, and on the left-hand side is the initial study they sent us. And as you can see, it's pretty much a whiteout of all the lungs. So I can't tell, what's pathology versus what's just really bad, severe atelectasis from anesthesia, which, anesthesia creates the most severe form of atelectasis. So we called this clinic up and said, "Hey, do you still have them intubated? And if so, can you retake the study and just, put some pressure on the reservoir bag to about 25 millimeters of mercury briefly while you take each image and retake the study because we need to see, if there's anything really going on in the lungs." And so that's what this right-sided image is. And you can see that as all these other lungs look pretty good, there's still an alveolar pattern in that right cranial with an air bronchogram and a smaller, less easily seen, but there's an alveolar pattern in the right middle lung lobe too. So when you have an anesthetized patient and you have control of the airway, that's a great opportunity to get really, really quality images. If you remember that feature of just using the positive pressure ventilation. And this is just fat in the mediastinum. It's a little bit of a chubbier dog, and he likes to put his fat in the mediastinum. That's not pathology necessarily. So, just to highlight, a rotated patient shouldn't have, one rib kind of extending dorsally above the vertebral column and one going ventrally. They should be, pretty much parallel with one another. And we want to make sure we're just keeping the thoracic limbs pulled cranially. Getting a little bit more into algorithms, as I kind of said, when you're using an abdominal preset or these whole body presets, they're sacrificing some things of each side. And so this is the same dog taking at the same time. And this is a thoracic algorithm that they chose for a thoracic image. And then they took an abdominal image too, in which they included a large chunk of the thorax. And I just wanted to highlight how much more busy the lungs look and how much more bronchial they look compared to the thoracic preset. And so you have to be real cautious with bronchial patterns, with whole body images, or even just abdominal images that include the thorax, because that preset is changing how things are looking. And so I exercise a lot more caution in interpreting the lungs for bronchial change in those instances. Another thing to think about is, we're taking these images at a snapshot in time. So these are, a single moment and they don't represent dynamics of any sort. And so, we can look at this image of the small, probably a toy breed dog or a Yorkie or something like that, or a Pomeranian, and the lungs look really busy. I mean, very interstitial. I don't see anything that looks particularly normal, in my opinion. But then you take it on the VD view and the lungs look a lot better. I mean, I don't see any of that interstitial pattern we were just seeing. And so this is all attributed to just really, really expiratory position at this point when they took the image. So you just have to be aware that this type of thing can be very uh, concerning if you're not considering that, oh, well, it's not persisting, so I can't interpret this as being real because otherwise, why wouldn't it keep showing up? So it has to be something transient or dynamic like atelectasis. Now, this dog could have something like lower airway collapse, so it is pathologic to the airway, but not. Moving on to pulmonary patterns, we talked about some normal changes and age acceptable changes like bronchial wall mineralization. Kind of the big three are your alveolar, your interstitial, and your bronchial. The interstitial is subsection into cut off there for a moment. Sorry, I don't know where I lost you guys. Um, let's rephrase this poem if you're just the persistence of pathology in which, if you have an interstitial pattern like this and it looks really busy, just keep in mind of how poorly inflated the lungs are here and how that lack of persistence means that it can't be true pulmonary disease. And so with pulmonary patterns, we talked about normal changes and things like bronchial wall mineralization. And then the big three are going to be your alveolar, your interstitial, and your bronchial. And the interstitial is partitioned into the unstructured and structured. The fourth one, vascular, is a nomenclature that's not typically used that much anymore, but you will come across it here and there. So I included it just in case you do hear it. For an alveolar pattern, we're basically looking at a whiteout,
Excuse
a
me,
soft
Greg.
tissue opacification of the lungs. Um, the technical definition is border effacement of the pulmonary vessels. But basically, it is going to be some type of soft tissue or fluid that occupies the area. So that's your alveoli and some of your tertiary bronchi and your bronchioles. It can be due to pus, to blood, to transidate water, cancer, or severe atelectasis even. And with air bronchograms, if you see an air bronchogram, that means that you do have an alveolar pattern, but you do not need an air bronchogram to call an alveolar pattern, if that makes sense. So great if you see it, that tells you that it is alveolar, but if you don't see it, that doesn't necessarily mean it's not alveolar. You're still looking for that soft tissue opacification without like a structure, like a nodule or mass. So a lot of these diseases are more subacute and acute. However, you can get things like fibrosis that can be alveolar at times, but more often they're in the acute and subacute phase. And just to keep in mind that distribution is just as important as the pattern because it helps you with your differential set. So think about where patterns should go or could go for different diseases, and that can help kind of narrow if that makes sense to the whole clinical picture. This is just a diagram to kind of help exemplify what we're talking about here, where the hexagons are the normal alveoli. The whiteout is your alveolar pattern. And because that whiteout is the same opacity as the pulmonary vessels surrounding the bronchi, that means that they're border effacing. And so now you have a highlighted bronchus, which is going to be your air bronchogram. And then the other point is that border effacement we talked about. If that alveolar pattern touches, say, the cardiac silhouette, which is that oval circle or that oval white structure, then they're going to border efface, and you can no longer make those margins out as clearly. And so these are just a few cases of alveolar infiltrates, in this case from pneumonia, because they often have a ventral and a cranioventral distribution. You can see that there's alveolar infiltrate all throughout here. An air bronchogram is forming here. You can still see the vessel, the artery right here, but the vein is border effaced here. And then we have a full air bronchogram here. Another area that's often missed by clinicians is the lung that is superimposed with the heart. Because mentally, you're expecting to have increased opacification where the heart is, because that's where the heart is. But it's an easy thing to forget to look more closely at the lung that is superimposed with it because there is increased opacity here where there's an alveolar pattern and an air bronchogram. So it's much easier to see those lesions here than here. So just keep that in mind when you're looking at the lateral views. In terms of differentials, pneumonia is going to be one of the most common, and these are examples of that. Atelectasis is another very common example, whether it's just from prolonged recumbency, sedation, or it could be a pathologic cause like a bronchial plugging from asthma or a nodule or a mass. Um, Pulmonary edema, where cardiogenic is going to be more common than non-cardiogenic. Hemorrhage can be from trauma like contusions, hit by cars, blunt trauma, um, can be from coagulopathies. or PTEs, or which is kind of in the infarct section. Neoplasia, more typically round cell than say, structured solid tumors. Although lymphoma, histiocytic sarcoma, they can develop distinct nodules and masses. Um, in pulmonary metastatic disease, so they don't have to be just alveolar or interstitial. So just keep that in mind. And then rare stuff like lung lobe torsion will also occur, but that's kind of getting down to the nitty-gritty, less extreme stuff. Here is a case of an alveolar infiltrate, both cranioventrally and then ventrally, and then caudoventrally as well. And so just to highlight where that air bronchogram is in yellow and where those alveolar consolidations are, this is another case of pneumonia. This is a dog with severe mitral valve disease, in which you can appreciate the cardiomegaly, the dorsal deviation of the trachea, the large soft tissue bulge in the region of the left atrium right here, and then the significant widening on the VD view. And then you have this nice alveolar pattern with air bronchograms, and an air bronchogram developing here as well. It gets a little more interstitial in the periphery, interstitial down here as well. But that, perihilar, caudodorsal, very classic left congestive heart failure for a dog. And just to highlight that, you often have more than one pattern. So we have alveolar, we have kind of more peripheral interstitial. A lot of times we have multiple patterns. What you want to try to do is determine what's the predominant pattern, and then what are the ancillary, secondary patterns or less severe patterns. And that'll also help you with your differential set. This is another alveolar infiltrate. This is in the right cranial lung field. Very nice distribution of air bronchograms, very well visualized. That's a really nice example. This is another pneumonia case. For interstitial, we're dealing with a similar disease process, and in many cases the same disease processes, but they're just doing it in a different way. And they're doing it in a less severe way most often, where there is cells or fluid or fibrosis affecting mainly the interstitium, and that's the space, between the vessels and between the alveoli and between the bronchi and bronchioles. It's the lattice that kind of keeps the structure of the lung intact and lets it expand and contract with all the elastin fibers. Um, Now, why it gets confusing, I think, is because the interstitium is so intimately associated with the airway that you can't really distinguish it easily, because it's all microscopic. And the other part of this too is that we're kind of oversimplifying disease and putting them into boxes to make our minds understand it a little bit better and to kind of categorize it a little bit better. But the reality is, like, these diseases transition in severity from interstitial to alveolar and back and forth depending on treatment and outcome and progression. And so these are a little bit of a construct that we're designing for ourselves. And then from a radiographic standpoint, you're just the main differentiation from interstitial from alveolar is just that it's not a pure whiteout. It's not pure soft tissue. It's going to be kind of this kind of grainy in between where it's hazy, but it's not white. It's not black like normal lung or nearly black, but it's not white. It's in between. So the technical definition is you have radiographically, you can still see the pulmonary vessels, but they're less distinct. That's the real difference. So another diagram just to kind of highlight that, you have that lattice surrounding the hexagon alveoli, and that's what's primarily being affected. And so it highlights how you can still see those vessels, but they're just not as clear. They're just not as normally clear as they should be. Another term is going to be unstructured interstitial for this. It's kind of lost its popularity as well. So a lot of people will just say interstitial, and what they mean is unstructured interstitial, because for structured, you're just talking about nodules and masses, and it's just easier to call it that. All your differentials for alveolar are the same for interstitial, and I think that's where things get a little confusing for people too. There are a few diseases that are more commonly interstitial, and that'll be things like pulmonary fibrosis, viral pneumonia, and cases of pneumonitis, whether it's from, a caustic inhalant or, uremia. Some people will call viral pneumonitis, so viral will sometimes be put in the pneumonitis section as well. So here's an example of an interstitial pattern where it's just kind of that hazy, it's kind of like that staticky old, TV channel look where, you can still see these lobar vessels extending out, but they're not super clearly defined. You can still see some bronchi and vessels hanging out peripherally, the tertiary ones, but they're not well defined. And it's not normal black lung either. Like there's a little bit of normal lung here, but everything else here is abnormal. A little bit of normal lung down here, but everything else is abnormal. This is a case of a dog with a pretty nasty infiltrate. It has kind of like this heterogeneous, almost grainy quality, which is typical of unstructured interstitial. And like I said, you kind of get that where you can still see some vessels extending out, but they're not well defined. And that's bilateral here. You do have some cranially as well. You do also have a small craniomediastinal mass. So this is a dog with pulmonary lymphoma. And so that's kind of a more classic distribution. Like I said, lymphoma can create nodules and masses. They're just not as common as this type of presentation. This is another case of pulmonary lymphoma where we have some alveolar infiltrate kind of up at the top, caudodorsally, and then as we go further ventrally, it kind of gradients into a more interstitial change and kind of cranioventrial, a bit interstitial. Some of this might be artifact because that limb, the brachial soft tissues are superimposed because these aren't pulled cranially. So structured interstitial, aka nodules and masses, they're a structured lesion that have, a pretty discrete margin. So these are going to be your Chang or Chang's lesions. So it's a cyst, hematoma, abscess, neoplasm, granuloma, and then some people add seroma for the S at the end. So this is a pretty simple case, a very large mass in the left caudal lung field. It's very well defined. Um, that's kind of what you're looking for. And then nodules as well would classify under structured interstitial. But again, that terminology is kind of lost favor, so people just say pulmonary nodules and masses now. Excuse me. This dog has two lesions in the lung. They're pretty poorly defined on this right lateral view. You can see one that's kind of craniodorsal, the larger one, and then caudoventrally you have a smaller one. If we go to the left lateral view, notice how the craniodorsal one is much better defined. And in fact, it's so better defined that you can actually see that it has a gas cavitary center, it has a gas cavitated core. And you could barely even see the lesion on this view. And now you can highlight, pretty specific details about it now. And then also notice that the caudoventral lesion is no longer even visible. So this is just to highlight, why we need 3-view thoracic radiographs. We want to make sure we're seeing all the lesions that are there. And based on these images, I'm curious if you guys have an idea of which lesion is where in terms of laterality. Do you think this craniodorsal lesion is in the right or in the left cranial lung lobe based on its visibility? So it's poorly visible on the right lateral view. It's better visualized on the left lateral view. Therefore, it should be in the right because this is the non-dependent lung being aerated now. And so the right cranial lung lobe is more gas filled, and now it's highlighting that soft tissue opaque lesion better. So that's where we're seeing it. And then the smaller lesion in the caudoventral lung field was left-sided, which is why you're not seeing it on the left lateral view because it's atelectatic. And so they're too close of an opacity together to differentiate on the images. Other structured lesions can have various degrees of gas cavitation and a peripheral wall. When it's something very thin and uniformly thin, like a bulla in the top left, that's going to be a benign lesion typically in terms of, compared to like cancer or, fungal infection and stuff like that, or parasitic disease. They can be problematic if they rupture, obviously, but they're relatively benign compared to, say, these other gas cavitated lesions in the central and bottom right, where they have a variably thick wall. That's going to be something like neoplasia or granuloma or an abscess. Moving on to bronchial patterns. It's kind of a simple topic, but I think it gets a lot of issue in that or it's problematic in terms of interpretation because of the bronchial wall mineralization for one part, and the other part is that in reality the sensitivity of radiographs for diagnosing bronchial disease is relatively low. So just because you don't see anything on your survey radiographs doesn't mean that there's not bronchitis. You could have early or mild grade bronchitis and have no radiographic detectable signs. And up to 60% of cases in the mild or early stages have no detectable signs. So it's worth keeping in mind that you don't have to see something for it to be there, and you don't have to overcall things in order to kind of justify your thought process. Um, my hierarchy of how I think about it is, you have a coughing dog. Okay, well, radiographs are normal. Okay, so what does that mean? That means either there's upper airway disease, there's a dynamic airway issue like tracheal collapse or bronchial collapse, or there's insensitive bronchitis that we're not seeing radiographically. So I kind of tier those three. So if it's normal thoracic radiographs, then okay, do a sedated upper airway exam, normal. Okay, do a respiratory PCR, normal. Okay. Maybe do a fluoroscopy or tracheoscopy to look for lower airway collapse if it's a breed that kind of fits with that model. And if that's normal, then we got to do lower airway sampling, do a BAL or a TTW and find out what's really going on down there. So that's kind of how I algorithmically look at radiographic patterns with bronchial disease. And that is just going to be inflammation, edema, and fibrosis. In end stage disease, it'll be bronchiectasis or abnormal dilation of the bronchi. You're mainly going to see thickened bronchial walls. That's the radiographic finding. And you really want to differentiate that from bronchial wall mineralization because you'll see bronchial wall mineralization as a solitary finding in normal dogs. So you can't use that as the sole differentiator for disease. A lot of dogs and sometimes cats, but mainly dogs, will often have some interstitial infiltrates surrounding the bronchi, just because there's inflammation going on, a little bit of edema, maybe a little bit of hemorrhage. And so you might see some of that parabronchial cuffing, whereas cats have more of a pure bronchial pattern. And so it's one thing that cats do for us, which I do appreciate from the radiology side, even though they don't usually more problematic in a lot of ways. Your differential sets are relatively limited, which is kind of nice. So you have your infectious causes, bacterial and parasitic more often than viral, typically. Your inflammatories like, lymphoplasmacytic bronchitis, your more rare conditions like eosinophilic bronchopneumonopathy, your allergic conditions, that's your classic feline asthma, and chronic inhaled irritants usually not acute inhaled irritants like smoke inhalation that usually causes like pulmonary edema as well and stuff. So it's not like a bronchial pattern per se. It's usually more chronic exposure. So everyone talks about tram lines and donuts. You're going to have increased visibility of these walls. They're going to be a little thicker. They may have some parabronchial infiltrates surrounding them. So this is a nice example of a cat who has really nice thick bronchial walls. You can see these end-on donuts with these thick walls. You can see these tram lines, and these are relatively enlarged too. They shouldn't be this big out in the periphery. So there's a little bit of bronchiectasis going on here. So it's probably more of a chronic disease with this case. But yeah, like I said, cats create really nice bronchial patterns typically. This is a case of severe inflammatory bronchitis in a dog. And just notice how he does have this bronchial wall mineralization right here, but he also has bronchial wall thickening and it extends out to the periphery as well. So you can see all these little donuts here out in the back, and they're pretty thick looking. So in this case, the dog has both, but one of these, is probably not as clinically relevant, this mineralization, because it has very nice, sharp, thin wall. It's very well defined, very conspicuous to your eye. Whereas the thickening, you can see it, but it's not as like sharp and thin. So that's what we're trying to look for. This is a pretty severe case of bronchitis, and this is also one that has that parabronchial cuffing that I was saying. This is actually a case of eosinophilic bronchopneumonopathy confirmed with lower airway sampling. So they can be pretty extreme looking, and that dog did really well, just immuno high steroid doses and looked remarkably better afterwards. But yeah, so this is that. Just want to highlight that parabronchial cuffing is something you see more typically with dogs than in cats. And it almost looks a little bit nodular, but if you look at each kind of nodule area, they always have a little bronchial circle in the center, and that's kind of going to help you differentiate that from, a more nefarious nodular lesion. Uh, Brachycephalic breeds are a challenge because they generally have um, more bronchial markings than other breeds, and it's really a challenge to determine, is this pathologic or is this just, a bulldog? Or is this primarily an upper airway issue with their, obstructive airway syndrome and tracheal hypoplasia, or do they have clinical bronchitis? And so they are a diagnostic challenge that I think um, I err on the side of caution. If they're progressing in a clinical way pretty quickly, but if it's more chronic and kind of static, then I'm less apt to call anything necessarily pathologic, just because they just tend to all have a bronchial pattern. This dog has a craniomediastinal mass as well. That's why it looks that way. Vascular pattern, like I said, not typically a common terminology anymore. But depending on if it's arteries and veins that are enlarged, or veins only, or arteries only, or if it's asymmetrical, like with like a PTE or something, it kind of helps narrow or widen your differential set to certain things. So in this case, it's a large breed dog with DCM, dilated cardiomyopathy. DCM dogs don't have as impressive of cardiomegaly as, say, your myxomatous mitral valve dogs, but this is a mildly enlarged heart, and there is some left atrial enlargement there. But just notice how that craniolobar vein is so distended compared to its adjacent artery. And then those pulmonary infiltrates, it's a mixture of interstitial and a little bit alveolar, but a lot of interstitial. So this is a heart failure case for DCM. This is a cat with some type of cardiomegaly. I think it was HCM, if I remember correctly. But if you look at these cranial pulmonary vessels, they're definitely thicker than the proximal fourth ribs. And you can also notice like these little striations coming perpendicular to these craniolobar vessels, and those are your tertiary vessels. And you really shouldn't see them. That easily or at all, really. So that further tells me that there's some vascular congestion, and you have vessels down here that are also coming off that are tertiary, that are enlarged, and then your lobar are pretty enlarged too. The heart itself is tall and wide, so there's cardiomegaly. If you look at the artery here, it has poor tapering peripherally. And arteries are more typically enlarged versus the veins in cats for left congestive heart failure. Often it's both, but if you just see the artery, that's not necessarily uncommon either for heart failure. And you're starting to see an interstitial pattern here, so some pulmonary edema developing here and slightly here too. Um, and there's also a scant pleural effusion. So you have your pleural fissure lines here and here and here and here. And this is a pleural fissure line here as well. And that's a feature of left congestive heart failure in cats, which is unique to cats, and you don't see that in dogs. Very quickly, this is a dog with heartworm. You have an enlarged main pulmonary artery, enlarged right caudal lobar artery, very tortuous and saccular in dilation. So it's pretty dilated even out to here, which is abnormal. And you have bronchial and interstitial changes as a component of the heartworm bronchopneumonitis. It's causing a lot of inflammation as well. So just kind of sum up what we talked about, we want to set ourselves up for success with making, the best images. The input of the image quality affects the output of how we interpret it and what we do with that in terms of patient care and quality. So really, really make sure that we're taking the best images possible. And I would encourage you to reach out to, say, your referral centers and teaching hospitals and academia where they have a radiology department, and you can send your technicians and assistants there, a few times a month or every 6 months, just to spend the day with them and see how they do things in terms of how they obtain images and what kind of tips and tricks they use. It would be super valuable for your staff, in my opinion. Um, Looking for persistence of a lesion is very important. If you only see it on one view, you have to speculate, is this an artifact? Is this, superimposed external debris? Is this a nodule in the body wall? Is this a superimposed teat? Um, you want to determine the primary pattern and then see if there's any ancillary. Like you said, it's often that there's more than one pattern. You want to try to pick out which is the primary and then use your differential set based on the primary. The distribution of the infiltrates is just as important as the infiltrate itself in helping your differential set. I think serial radiography is something that's not talked about enough in that, we want to make sure these patients are progressing in the right direction. So from a therapeutic standpoint, it's very important, but also from a diagnostic standpoint too. If they're not getting better, or let's say you think it's pulmonary edema and you start giving them diuretics. Well, if that starts to improve significantly within 12 to 24 hours, it's not going to be pneumonia. It's not going to be, like hemorrhage. It's most likely going to be, edema, like you called it. So, and then lastly, just seeking consultation, I think is very important. And I don't mean that just from like a general practitioner to a specialist setting. I seek consultation with my mentors and, my colleagues. And my resident mates, and my wife's an internist, so I pick her brain about stuff that I don't have such a smart head about. But I think it's very, very, very valuable to expand your knowledge base based on just reaching out and asking, "Hey, have you ever seen this before? What do you think of this? Am I missing something?" Um, yeah. And these are some resources that you guys can go through in your own time. The first two are websites with a bunch of cases where they show you the history, presentation, pertinent exam and diagnostics, the images, the radiology report, and they often have confirmation by like histopathology and whatnot. And then the textbooks by Thrall are very valuable. The Atlas is extremely valuable for um, juvenile orthopedics and normal growth. So definitely get that atlas for that alone. And the BSA VA manuals, the British manuals for radiology, the thorax and the musculoskeletal are excellent. The abdomen's okay. So we're at the end now. Sorry I rushed that a little bit at the end, but we're happy to take questions.
You. Thank you so much. Appreciate that. I have a few questions for you.
All right.
Um, does the size of the animal change the view of the whole body views? Like, it's a full body Yorkie. Would that
Right.
show better lung activity versus a larger breed or even medium sized?
That's a good question. Um, uh, I would say yes, the size does matter. As you get smaller and smaller, the whole body versus just thorax or just abdomen imaging becomes less of a problem. So as you get smaller, especially when you get like ferrets and exotics, but yeah, your toy breed dogs. Um, I would say it's a little bit less of a problem, but you still have the issue of the algorithm preset being, justifying certain things and making things look different, which is a problem. But also, what I find a lot of times, even if they're a really small patient, what tends to happen is that the field of view is still extremely large. And so, that larger dog's taking up more of the field of view because physically, that's what it does. But when you have a tiny dog, often the staff is not appropriately collimating. And so you have a big field of view with a lot of blank peripheral space. And so it's essentially the same thing in terms of a really low diagnostic yield, where you only have a very small number of pixels actually looking at the lungs.
So, so wonderful. Thank you so much. Um, Another question. What is the quote air bronchogram? Is that a specific pattern?
Yes, the air bronchogram is an air bronchogram is seen with an alveolar pattern. And it is basically where the alveolar infiltrate highlights the lobar bronchus of that lobe. because there's soft tissue everywhere in that lung except for the lobe, except for the bronchus. And so what it creates is what we call an air bronchogram. And basically, if you see an air bronchogram, then you can say for sure that you have an alveolar pattern. But you don't need to see an air bronchogram to have an alveolar pattern, if that makes sense. So if you see it, then you can confidently say there's an alveolar pattern. Just because you don't see it does not mean there's not an alveolar pattern.
Very helpful. Um, any quick reversible sedation preferences?
Hmm. I mean, dexmedetomidine is an excellent drug. It's extremely safe. I know there's a lot of nervousness around the drug, um, but I find that I mean, I've seen some uh, very high doses given, um, sometimes by mistake, miscalculation, and the animals are totally fine. So I think just familiarizing yourself with dexmedetomidine can be very helpful. Um, I think that butorphanol can be a little bit problematic because it often causes panting. And so whether you're doing that for an ultrasound or taking radiographs, that panting is going to have a negative effect in a lot of ways. So I try to avoid torb for that reason. Um, I think alfaxalone is getting a lot more use, but I know I believe it's on a shortage now, which really stinks. But that's all I can think of at the time. Gabapentin for cats, a few hours before they get in can be very helpful too. Um, that's my pharmacology knowledge on that.
Thank you. Is the best way to differentiate between alveolar and interstitial that alveolar is more of a whitewash, whereas interstitial is hazy, but you can see behind it?
Yeah, I think that's a good way to put it. Yeah, I think of it like a complete whiteout is alveolar, like it's just pure snow, like just soft tissue opaque, but without like kind of the structure of a nodular mass, basically. So that's how I tend to think about it. And then, like you said, it's kind of a more haziness for interstitial. It's kind of like that kind of grainy gray where it's not purely white, it's not black. It's an in between, and it's often kind of granular and hazy. And you can still make out some vessels, is kind of the main point. Is like you can still kind of see some vessels here and there. And so you're not a pure whiteout, like you said. So yeah, it's kind of that easy way of differentiating. Like, is it white as snow or is it kind of in between?
And then could you go back in your presentation? I think it's around perhaps slide 21, I think, or so. It was just when we lost you for a moment, and I think it was around
Oh,
you're talking about expiratory patterns. So that I think we're around there.
yeah, I think we're
Yes,
talking
one back, I
about.
think here is where we were.
Okay.
One
Um,
forward. Sorry.
Yes. Okay. Sorry. Yeah.
Thank
So
you.
this was a case of a dog that was anesthetized for a dental, and the dog stopped uh, oxygenating well and was having difficulties under anesthesia all of a sudden. So they took radiographs while the dog was still intubated, and they sent it to us. And we said, well, the whole lung is very almost alveolar, mostly interstitial. We can't see if there's disease there necessarily. And so we said, hey, we called them up and we said, hey, if you still have the dog intubated, can you um, positively inflate the patient by just, closing off the reservoir and then uh, squeezing the reservoir bag to about 25 millimeters of mercury briefly while you obtain each image. And that's what they did. And so you could just see the difference between how we have a much better aerated lung where it's much more black, except for in that right cranial lung field where there's still an alveolar pattern. There's that air bronchogram, which tells you it's an alveolar pattern. And then there is a small alveolar pattern here in the right middle lung, which is less clearly visible. Um, So that's just to highlight how if you have an intubated patient, you have complete control of their airway. And so it's an excellent opportunity to get really, really great radiographs by positively insufflating them briefly for each image.
Can you keep going maybe one slide more after this, I think?
Okay, and then this was just highlighting how the patient's very rotated over here. I want to make sure that the ribs are not so divergent where one is extending above the vertebral column and then one is going below. They should be kind of on the same plane, and that we just have to pull the thoracic limbs cranially.
Wonderful. Any other questions that people have?
Oh, this was one too, I think where we got lost in. I was just highlighting how the persistence of pathology, it looks like there's a lot going on here that's wrong with this patient, but what this comes down to is just a severe atelectasis and poor pulmonary inflation because we don't have it persisting on the orthogonal VD view where the lungs are much better aerated. So I think that's what I think I got cut off here as well.
Thank you. Last question, perhaps. Someone asked if you could tell us about one of the most challenging X-ray cases that you've ever had.
Hmm. I think that's a good one. I mean, pulmonary thromboembolisms are always very challenging, but they're not as common. I would say a better example would be um, in some cases, dogs with heart failure will have an interstitial pattern or even alveolar sometimes that's cranioventral. And that becomes tricky of is this a pneumonia case? And incidentally, there's cardiac disease, or is this an atypical distribution of cardiogenic pulmonary edema? Um, and so that becomes difficult to say, which is it? How do we treat it? Um, After experiencing a few of those, my go-to is always to start with the diuretic, unless there's something obvious like a fever or a severe leukocytosis with a neutrophilia, something else that would highlight an infectious process more than anything else. So and then like I said, with serial radiography and how serial monitoring is important, we would recheck that patient within 24 hours after starting the diuretics. And if there's a significant improvement, then we know it's not pneumonia. But those are, yeah, because it's usually like these moderate to severe mitral valve disease dogs. And then there's just like this weird pattern that's more cranioventral. And you're like, that distribution is not typical. So occasionally we'll see that. And my go-to is to still treat it for heart failure and then just follow up very closely.
Two more questions. Sometimes miliary patterns we see on radiographs. Can you describe that, Pete, please?
Yeah, yeah, we didn't go into that. I should probably add more, although I don't have much time to add many more cases. But miliary patterns are essentially very small nodules. And so it is typically associated with fungal infection, but you can see it with metastatic neoplasia as well.
And then, is there a preference of DV versus VD?
That's a good question. Um, the answer is it depends. If you are worried about a cardiac patient, DV is typically preferred. Um, for a significant amount of pleural effusion, a VD is preferred because the fluid will sit more dorsally, and so you can see the heart better. There's going to be less border effacement. Um, I generally want VD for most things, except for cardiac. And I'm not like strongly saying, you should only do DV for cardiac. Um, I would just say add a fourth view so you have a VD and a DV in that case. I think the problem with DVs though is that staff aren't used to doing them, and so more often the patient's not really set straight really well, and so. That's my only reticence about saying that you want to do a bunch of DVs in a lot of instances. I would say stick with VD for most of the time. And if you have a cardiac patient where you're worried about potential heart failure, or you really want to look at those caudal pulmonary vessels for, things like heartworm or something like that, then I would get a DV in addition and make it a four image study.
How do you recommend positioning for a DV?
Um, the main problem is that they're sitting on their sternum, which is relatively narrow. It's kind of like, a boat shape, if you think about it, how the boat sits in the water. And so they're more likely to tilt, especially if they're deep chested, more likely to tilt one side or the other. So sometimes radiolucent wedges, if you have them at your clinic, can be helpful to stabilize them in place. Um, Making sure that if their back legs are flexed to make sure that they're even sitting down, not one kind of splaying out because that'll tilt their whole body. So just making sure everything's kind of symmetrical in terms of their limbs and using the wedges. Sometimes putting tape over them, like tape it to one side of the table over them and then onto the other to kind of stabilize them further. Those are little tips that I found to be helpful. But yeah, it's that rotation that's typically the problem because the sternum is much more narrow compared to the back.
Wonderful. Thank you so much. I think that's all of our questions for this evening. Thank
Great,
you so much. Everyone is saying thank you for the presentation, how informative it was, and they really enjoyed all of the real world examples that you included.
great. Thank you guys so much. I had a lot of fun doing this. Um, yeah, this was great. I hope you guys learned a few things. Like I said, just one or two things, and I call that a win, at least for that. That's what I judge it by and criteria for when I go to CEs.
Thank you. Thank you all for all of your questions and appreciate everyone participating and looking forward to everyone joining us again for a future webinar. You will all receive the recording of tonight's webinar in an email along with your CE certificates in the next few days. So just look for that in your email. Thank you all so much. I hope you have a wonderful rest of your evening. And thank you again, Dr. Imbriano. We so appreciated your time and teaching and all of your answering of all of our questions.
Thank you.
Good night, everyone. Take care.